So I was asked to talk about the strengths, challenges, and future potential of the European Reference Network for Rare Neurological Diseases. I'm the lead of the Irish site. These are my disclosures. So the European Reference Network for Rare Neurological Diseases covers these 6 disease areas, and all of the information is on the website. It's very helpful if you're interested. I thought it would be useful to go through the timeline of how this happened in Ireland. It was a very long and frustrating process. So the call went out in 2019. We submitted to become a site in November. For various technical reasons, we had to resubmit all our information a year later, and then the approval letter finally arrived in December 2021, and we were officially members in January 2022, so over 2 years for the initial bit. And as any ERN site knows, a core mandatory requirement of being a site is that you have to have a registry. So it took 6 months to get a data sharing agreement signed between our site and the ERN, and then we had to submit ethics, and that was another lengthy process, and we got ethics approval in June 2023, so 18 months after we became a site. And we finally consented our first patient to the registry in July 2023, so very long process. And then it comes to resourcing. So we had no resources, we had no admin. I unfortunately had no fellow or funding, and so I was doing this with my colleagues on the side of a busy clinical job. And just entirely serendipitously, I got this email out of the blue to my Trinity email account, which I never look at. I don't know why I looked at it on this occasion. And it was only when I was putting the slides together that I realized that this email arrived on April Fool's Day, and I'm not sure why I replied. But it was from this man in America who I'd never heard of. He emailed me completely out of the blue. He'd found my name on the internet, and he said, for various reasons, he wanted to donate money. So that was exciting. And this is an extract from his email, and he finished off by saying, "P.S. Lest you think I'm some nutter, please see attached." And he attached a newspaper article about himself. So he was coming to Ireland for a wedding and said he would meet us. So he came out to Tallaght and met myself and Sean O'Dowd, who runs the cognitive service in Tallaght, and we showed him around the clinic. We told him about the ERN, RND. This is Norbert here, Norbert McDermott, who left Ireland 35 or 40 years ago for a brief trip and never came back. And immediately he offered to give us €100,000 per year for 3 years to help us set up our registry and to fund a neurodegenerative ANP for our clinic. So amazingly generous, and came just at the right time, thank goodness. We were able to leverage the grant to make a permanent post. Our hospital were very supportive. And so then we were able to fund a senior HSCP role for the cognitive clinic and an administrator for developing our ERN R&D registry. And this is some of us who run the ataxia clinic in Tallaght, with Colin, our Norbert-funded administrator, in the middle. So the beauty of the ERN R&D registry is that it is a very simple data set. It's only got 12 data points, which are extremely simple. You can basically get it from the letters. It does include an ORFA code and an OMIM code, and then there is a disability score depending on which disease group the patient has. But that's basically part of your clinical assessment in clinic anyway, so it really doesn't involve too much extra from what you would do in clinic to get the data. So in practice, what happens is we run the National Ataxia Clinic in Tallaght. Colin, our administrator, sits that clinic. When the patient arrives, he consents them. He puts the CRF along with the relevant disease scale on the front of their chart. That comes into clinic. We do the clinical assessment as usual, just tick a couple of boxes on the form and hand it back to Colin. And then he goes into Spider, gets the pseudonym, and uploads it into an Excel spreadsheet. It is very basic. And this is one of our spreadsheets, maybe from last year. It's all pseudonymized, so I don't know who any of those patients are. So that's the registry. And then once a year, this Excel spreadsheet is uploaded to the ERN R&D cloud, and they're all amalgamated. Every other site does the same. The registry objectives are very straightforward, as you would expect, to improve the care of patients, particularly around diagnosis and standards of care, and to harmonise data on rare neurological disease patients across the EU to address epidemiological, cohort, care quality and care resource questions. The data is available to researchers through a data access committee, like you've heard from other ERNs. The data is monitored at regular intervals, so after the annual upload process, it's looked at centrally, and then aggregated data is made available to all the healthcare providers, and it is available also on the ERN R&D Registry website if you're interested. So this is our data. So we consented our first patient in the middle of 2023. We did try to retrospectively consent patients for the previous year, but it was just very time-consuming, and we didn't get very many in there. And you can see year on year the increase in patients consented and the disease breakdowns. So we run the National Ataxia Clinic, and most of our patients consented into the registry have ataxia. And then we also have a cognitive service and 2 movement disorder clinics, and we consent patients with rare neurodegenerative syndromes into the registry also. This is the aggregated data from the ERN R&D, and you can see year on year new sites being enrolled and the number of patients going up. You can also see the common rare disease, ataxia and dystonia. And what I think is quite interesting looking at this data is that, you know, considering we're a very small country and a very small site, we have contributed a third of patients with corticobasal degeneration in the entire ERN R&D registry and 20% of the MSA patients. So a small site can still contribute a very significant amount to these registries. What's also interesting is the majority of patients in the overall ERN R&D registry do not yet have a genetic diagnosis, which is quite different from what we see in our clinic, where 2/3 of patients with ataxia, for example, have a genetic diagnosis. So the strengths, at a micro-local level, I would say the fact that we already had cohorted clinics made this a much easier process. The fact that we got resourcing from our generous benefactor to appoint a neurodegenerative ANP who consents the patients in the cognitive and the movement disorder clinics, and our ERN admin who consents all the patients in the ataxia clinic, and we could not do it without those people. At a macro level, the lead site is Tübingen in Germany, and they are extremely organized. So there is a bit of a carrot and a stick approach. We are regularly scored. So each year we get a score based on, you know, whether we've uploaded to the registry, how many patients we've enrolled, have we been involved in developing guidelines, have we attended all of the working group meetings. You get points deducted if you don't attend. And then every year they send this graph showing where you compare with everywhere else. We're somewhere in the middle and have been told we're doing okay. But some people are getting minus scores, so I wouldn't like to be down there because they threaten they'll kick them out. I think the reason the ERN R&D registry has been so successful is that the CRF is extremely simple. It's only 12 data points. It makes it easy to collect. The upload process is easy. And this is Holm Grasner, who some of you might know. He has won many awards for leadership in rare diseases. He is the lead of the ERN R&D primary site. So the challenges, I mean, you've heard some of the challenges from previous speakers, but time and resources really are a big challenge. It's very difficult to do this as a busy clinician. And to any funding agencies, you know, you do need to, even though this seems like a simple job to recruit to a registry, you need resources. You need someone dedicated to do that because it's just impossible to do it as a clinician. Cohorted clinics are essential. Sometimes these patients pitch up in my other clinics, and when the process isn't there and the people aren't there, it's very time-consuming and labor-intensive to recruit them. And there are cross-site issues. So we are a consortium, but as yet have had difficulty getting other sites' data to upload. So it is still a work in progress. But I would say the potential is huge. So this is a snapshot of the genetic diagnosis in our ataxia clinic that we published a few years ago. And you can see a large proportion of patients have a couple of more common rare diseases, but a lot of patients have pretty ultra-rare diseases where there might only be 1 or 2 patients, and this is replicated in all of the sites. So it's very difficult to advise patients with these kind of diseases, what is their prognosis when you only have a handful of patients. And it's very, you're basing all of the evidence is on case reports and very small case series. And that's the benefit of a registry. You can put all of those patients together. And some of you may have seen this paper a few years ago in the New England Journal. So a targeted antisense oligonucleotide was developed for this particular patient who had an intronic splice variant, and it partially restored normal splicing. And this One Mutation, One Medicine group, again led by Holm Grassner from the ERN R&D, has developed a consortium to try to use the same technology to develop antisense oligonucleotides for rare intronic splice variants. And they looked at this in ataxia telangiectasia, which is a rare cause of ataxia, and they found that 15% of ataxia telangiectasia had an intronic splice variant, which was potentially or probably amenable to this approach. And since then, individualized antisense oligonucleotides have been trialed in a number of rare diseases, including ataxia telangiectasia, with success. So how does that affect our patients? Well, POLR3A is a rare autosomal recessive cause of spastic ataxia. We have 3 such patients in our clinic, and 80% of patients with this particular genetic type of ataxia have this one specific intronic splice variant. So the University of Heidelberg reached out to the ERN R&D and asked sites to get in touch if they had patients with this intronic splice variant, and 21 sites produced 85 patients with this ultra-rare disease, and we are now enrolling them into a natural history study, alongside which the 1M1M group are designing an antisense oligonucleotide targeting this particular intronic splice variant. And the idea is that when that treatment is ready, hopefully soon, patients who are already in the natural history trial will roll into a treatment trial. So this is like a treatment for an ultra-rare disease coming down the road. So to finish up, I would just say that the process is extremely lengthy. It's very frustrating and time-consuming, but if you're going through it, just put your head down, you'll get through it in the end. It's worth it. Dedicated resources are essential. It cannot and will not be done by clinicians alone in the clinic. I would say to people, cohort your clinics. It makes life much easier for registries. Keep the CRF simple, develop a streamlined process, and I think hopefully you can see that this already is promising real tangible benefits for patients with rare disease. I'll just finish by thanking my collaborators and Norbert, who gave us the money for our admin.